Welcome. We've got a daytime session today where we're going to be learning from Dr. Fred Cohen about complementary and alternative treatments. To tell you a little bit about the mission of Migraine Headache Australia, we are a division of the Brain Foundation, and our remit is really threefold. We fund a research project every year, or at least we try to, and we do most years into migraine and headache. We aim to provide trustworthy and reliable information, such as this medical presentation that you will be sharing with you today, as well as medically reviewed articles on our website, tools and resources, and things like the doctor treatment directory, discussion guides for doctors, guides for the workplace, and more. And we also advocate and support people living with migraine and headache disorders. So each session this week, we're going to be highlighting a particular area of work that we've been involved in so far this year. I know that the year's not ended, but there's been a lot that we've been doing. And so this session, we're going to be talking about a GP training webinar series that we did very recently for primary care physicians in Australia. And we had some incredible feedback. We spoke about diagnosis and management, and this really came out of some of the research that we did earlier in the year in partnership with Jean Howes for Women's Health, where we identified that the experience that we have in primary care is often formative. And if we have a good experience, it can go on and lead us to a helpful pathway in migraine treatment and management. But conversely, if the experience is not a positive one, we often sidestep the medical care and we take things into our own hands. And sometimes that's not for it's not for the best. Sometimes a medication plays a really important role in the management and control of migraine, and certainly medical supervision if we're taking multiple treatments. But fortunately, we had over 900 people register for this. The feedback was incredible. We got excellent, amazing, very good, very commonly shared throughout the session. And this session is still available. In case you are a GP, you can still register for this. You can contact us, info@brainfoundation.org.au. If you're interested in that link, we can send a copy of this to you, and you can get accreditation for it. It is CPD accredited, which means if you're a doctor, it helps count towards the training hours required for you to maintain your practicing certificate. So this was a great initiative. It was the first time we as Migraine Headache Australia really spearheaded this program in partnership with the Headache Society to train doctors and primary care physicians. So that was something we're really pleased about. And a quick thank you to our sponsors for today, AbbVie, Brain Foundation, Pfizer, and Lundbeck. Without their support, we wouldn't be able to reach nearly as many people or run these sessions the way we do. And so we really are grateful to them. And to confirm, you are in the right place if you have migraine or headache yourself, if you're a parent, partner, or caregiver, if you'd like to connect with others, or if you do want to ask a question. If you want to learn about complementary and alternative treatments, you are also in the right place. That's what we're going to be talking about today. And we've also got a support group. This is a peer support group. It's on Facebook. I acknowledge that not everyone uses Facebook, and that's absolutely fine. It's not mandatory. But if you are feeling some of that isolation, if you do like to be able to bounce ideas or thoughts or comments or something your doctor said maybe to someone else, and you don't have anyone in your personal life, this may be a nice way to do that. This is a private, closed group that you can request access to through Facebook to our community. Now, a quick introduction to our speaker today, Dr. Fred Cohen. He's an assistant professor of medicine and neurology at the Icahn School of Medicine at Mount Sinai in New York City. So you'll notice he is from the US. I have seen him personally up on stage teaching headache specialists about some of the latest and greatest treatments, research, and best practices. He is a foremost expert in this space, and don't be fooled by his young appearance. He is wise beyond his years and is highly respected amongst his senior colleagues and peers within the headache field. He's also one of the few headache specialists in the US that's trained both in internal medicine and headache medicine, and he's already a published author across several medical journals, including Headache, Cephalalgia, Pain Medicine, and Neurotherapeutics. And he serves on the editorial board of Headache. So he is already a wildly accomplished and highly respected headache specialist, and I'm really excited to have him here today with us. We also have someone from our team, I was about to say Dr. Nick Grundy. She may as well have done a doctorate with the amount of work that she's done, but she is not a doctor. Neither am I should say. She's our grants program and digital lead for Migraine Headache Australia and the Brain Foundation, and she is also a superstar. She's going to be helping us in the comments and moderate today. So thank you very much, and welcome to Anik. And lastly, if you're not familiar with myself, my name is Carl Cincinnato. I'm someone with lived experience, and I'm very passionate about speaking out about migraine, as you can see in some of the media clips and speaking opportunities that I've been so fortunate to have. And despite years of work in this space, there is still a long way to go. And so I'm very passionate about getting the message out to the public, to speak on behalf of those who might be trapped in that that dark room struggling with chronic pain, which is where I was not too long ago. So thank you for having us. So with that, we're going to go to the presentation now, and just bear with me while we pull that up.
Hi, my name is Fred Cohen, and I'm a headache specialist in New York City at Mount Sinai Hospital, the Icahn School of Medicine. I also am the medical director of Headache Intervention, a headache practice in Brooklyn and Queens, New York. And I'm going to be talking about complementary and alternative treatments for migraine. These are my disclosures, none of which are relevant to what we'll be discussing today. So going through this talk, we're going to be starting with understanding, migraine and why alternatives matter, and the variety of these different treatments, including mind-body therapies, supplements, nutraceuticals, manual therapies like acupuncture, and also the safety and practical guidance we do in this, and then key takeaways about using this, because there's going to be a lot of different treatments and methods and modalities that, could be applied to a variety of different migraine patients. So understanding migraine, because migraine is a complicated chronic neurological disorder affecting millions and millions worldwide. It's estimated 1 out of 6 individuals have migraine, and 1 out of 5 women have migraine. The Global Burden Disease Study found that it is the #1 cause of disability for women ages 18 to 50. So this is a serious thing. This isn't just a headache. And again, this is a complex disorder, and not to put a stigma to it, meaning that we don't fully understand what's going on. I always tell my patients, you figure out what a migraine is completely, you win the Nobel Prize in medicine. Now we understand, chunks of it in pieces, that's how we made targeted therapies and whatnot, but we still don't get the full picture. So, there's many pharmaceutical medications and therapies and injections that are effective and safe. But the point of this talk is highlighting other alternative and complementary treatments as another viable option. And typically, for most of my patients, that it's a combination of these treatments. Both we have our pharmaceutical ones and alternative ones combined for a complete treatment strategy. And that this isn't all anecdotal. There are studies, clinical trials, et cetera, that have shown reducing headache frequency and improving quality of life with mind-body practices and certain nutraceuticals. So I'm going to go first into what mind-body therapies are, and that's a couple of things, one being yoga. So yoga is a very, wide, approaching school. I'm not a yoga master, so I can't talk, different kinds of guru schools, etc. But overall, yoga as a form of meditation, there has been actual clinical, trials done, meaning a sham yoga versus, an actual technique, and has shown to have evidence of reducing migraine attacks as well as the pain sensitivity. You'll see through the study things I mentioned like HIT and MIDAS scores. These are metrics used by clinical offices to assess burden, like how much is migraine affect you. To give an example, MIDAS asks questions about how often are you missing school, work, etc. So it's a good way to establish what kind of a burden impact that it's having. So we've seen with yoga that also has a decrease with that, as well as decrease in medication use. Now there's also that mindfulness-based stress reduction. This is such as meditation. It also has been highly effective as a method for frequency reduction, and that other methods like Tai Chi has also shown prominent evidence for migraine prevention. And of course, given that this is not a pharmaceutical medication, there's not really adverse effects. It's not like, okay, if you do this, it's going to affect your liver or something like that. Now, I brought up stress before. Let's talk about stress. Now, stress has been reported by various population and epidemiology studies as the #1 trigger for migraine attacks. And The exact relationship of that is not fully understood. However, that it's been associated with the incidence of migraine, chronification that's going from episodic to chronic migraine, frequency of migraine attacks, and burden. And the way I explain this to my patients is, well, what is stress? Stress, what is the brain doing? The brain is a computer, if you will, looking at stimulus. And stress could be a negative stimulus. And it's commonly associated with, states of inflammation. Now, listen, the world is a wild place. I don't have to speak what's going on in my country right now, but I don't tell patients, yeah, just de-stress. No, you don't just tell a patient to do that. But why I bring this up is it's important to be aware of that in taking into account, like, okay, I have my medications I'm taking, I'm going to do some meditation. What are my current stressors? So it's a big thing to keep in mind when thinking about mindful body practices. Now, manual therapies, which a lot of it is acupuncture, has been commonly estimated by patients in my clinic. Like, oh, hey, Dr. Cohen, what do you think about acupuncture? And there has been some clinical trials assessing acupuncture. Now, one way to describe acupuncture is in Western medicine, by MDs and DOs. Like, dry needling is a term we use. And one of the processes that going through certain, you can think of it as not stress areas, certain pinpoint locations of doing an acupuncture needle, which is a very fine needle going into muscle, finding trigger points and twitches, etc. And there have been clinical trials that have shown reduction in pain versus not acupuncture at all. Other kind of manual therapies include physical therapy. I'm a very big fan of physical therapy. For a lot of migraine patients, there's some kind of cervicalgia, neck pain, neck stiffness, etc. And it's a big question: what came first? Chicken or the egg, the neck pain or the migraine? And I don't focus too much on that. It's like, hey, let's treat it. And physical therapy, massage therapy are great, treatments to have for that. Now, I get asked about chiropractic treatment a lot. I wouldn't call myself anti-chiropractor. No, I think there's benefit in that. However, I must urge caution of neck manipulation specifically, not back or elsewhere, but on the neck. There is concern, and I've seen it especially when I used to work in the hospital of cervical artery or carotid artery dissection. So I always mention caution about specifically neck manipulation. Another manual therapy would be the date piercing, which, as you see by the illustration, it's a piercing that goes by the septum and tragus. There's been some trials that have shown, it reduces migraine severity. The data is questionable. If patients ask, say, hey, if you like a piercing, go for it. But, I'm not, it doesn't have a high quality of evidence, I would say. Now, transitioning away to supplements, vitamins, and more. So on this, we're going to be going through a lot of things. Like on the screen, we have magnesium, CoQ10, this fish oil, that plant is butterbird, vitamin D. There's a lot of supplements. And it's very common that, almost all my patients are taking some form of supplements. Now, there's not one supplement to rule them all. Yes, there's some that have higher evidence than others, but there's many. And again, as with all migraine treatments, it's finding what is effective for you. So these are what I call the key supplements, the trifecta. These are the most common, I would say, used supplements with probably the highest quality of data: magnesium, riboflavin, and CoQ10. I'm going to go more individually in each of those. I just wanted to bring these up. Like if there were like 3 supplements I want you to remember, it's probably these 3. Mag is probably the most common used. Riboflavin, these you see in stores so much. CoQ10, a lot of people maybe already taking it for cardiovascular reasons, decreasing blood pressure, etc. And as I said, there's been many trials conducted assessing the evidence for this. So let's start with magnesium. Magnesium, essential mineral in the periodic table of elements. I was a chemist before a doctor, and that one reason why we think it affects migraine is the way it works is it regulates neuronal excitability and the vascular tone. There's also an hypothesis that those with migraine may have low magnesium levels in their cerebral blood flow. Now, when blood goes to the brain, it actually passes a really strong filter, the blood-brain barrier. So while there's a question of maybe those who have migraine that maybe not as much magnesium is reaching there, and that's why mag supplements are effective. Because if you were to get a magnesium blood test done, you probably won't be deficient. It's not common to be deficient. It's actually a bit hard to be mag deficient, but magnesium supplements still help a lot of people. There's been a variety of clinical trials and meta-analysis that show that oral magnesium can be effective. It's something given for the acute setting, meaning when people come in for an infusion, when they go to the emergency room, that IV magnesium has shown to be effective. And what's great about it is it's inexpensive. I just actually came back from the International Headache Congress, and one of the major topics we spoke about was access. In some countries, drugs we take for granted might not be accessible. Mag is almost everywhere. It's very cheap too. So it's not something of, oh, is my patient going to have insurance approve this, or they will be able to get this? It's overall well tolerated. However, the most common side effects are gastrointestinal related ones. Magnesium is actually one of the oldest forms of a laxative, milk of magnesia. So the common side effect is it could cause loose bowel movements. If you take a lot, it will cause diarrhea, gastrointestinal discomfort. Something to keep in mind. There's various formulations that exist, which I'm going to go into in my next slide about different absorption and effectiveness. The most common formulations are oxide citrate and glycinate. These are probably the most that you see in the store. If you were to look at any supplement of magnesium, these three be the ones you see the most. Now, patients ask me, Dr. Cohen, which one should I use? And I tell them, well, experiment a bit, meaning for some patients, they might find one of these forms works better than the others. There's no way to, predict which magnesium you're going to absorb best. It's different for everyone. Now, glycinate actually typically has a more gentle effect on the stomach, so that's a very popular one. However, it has been a bit more expensive than citrate and oxide. That's why in most brands of like generic multivitamins, etc., you'll see citrate or oxide used. But they, again, have a higher gastrointestinal side effect profile. So if you start with oxide, it gives you, GI upset. Don't be discouraged. Find another formulation that might be effective for you. I've had patients that try 3 or 4 formulations before finding one that, oh yeah, this one doesn't bother my stomach and it's, working well for my migraine. Other more additional forms, not as common, is lactate. Therarenate is actually becoming more popular. I see a lot of, let's say, designer supplements using it. It is costly. I'm not saying I recommend that one. And given that it's newer, there's not as much migraine data. It's actually popular in people who are concerned about cognitive stuff, so using it as like a cognitive brain supplement. Sulfate is typically the IV one that you would see in emergency rooms, so obviously you're not taking that at home. But again, the highlight of this is there's a lot of different formulation. So finding what works best for you. And again, a hallmark I'm going to talk about later is what works best for someone might not be what works for you. So again, if you get a friend that says, oh yeah, I take mag oxide, it's amazing, it helps me so much, but you take it and it's not effective, don't be discouraged. You got to find what works best for you. Another popular supplement is riboflavin, vitamin B2. Now I want to stress this, vitamin B2. There's a lot of B vitamins. And it's a common place that patients will leave the office thinking, oh, I'm taking a B vitamin, but they're taking B1, B3, B6, B12, B2 specifically. And riboflavin is the thought of why it helps with migraine is that it works on mitochondrial energy production. Mitochondria is the powerhouse of the cell, and it reduces oxidative stress, which that is an inflammatory process. And it's thought that maybe a deficiency can contribute to migraine attacks. High doses, when I use the word high, meaning higher than what's typical, like if you were to look at a multivitamin, the amount usually there's 50 milligrams, so 400 is clearly a lot more. So the average dosing is around 200 to 400 milligrams daily, typically taken in the morning. There's been studies that show it comparable to common migraine preventatives like propranolol or valproic acid. So again, like I said, these, just like MAG, there's been high quality evidence of data shown, and it's pretty well tolerated. The main side effect is a light green urine. So a little funny story about myself. I'm a migraine sufferer. I say never trust a headache doctor who doesn't get headaches. When I started taking riboflavin in college, no one told me about the green urine thing. I felt like my kidneys were dying. And I'm like, uh-oh, I'm just being Gatorade. No, it's excess riboflavin. It's a water-soluble vitamin, so any excess your body just gets rid of, no problem. So that's not a concern. When looking for dosing, again, you want to find specifically riboflavin supplements. If you get what's common is patients get a B complex. If you were to look at the nutritional facts of it, you'll see those typically only have 50 milligrams. That's not enough vitamin B2. So be very, careful when looking at dosing if you want to try this. The third one of the trifecta I call is CoQ10, coenzyme Q10, also involved in mitochondria antioxidation. And again, deficiency is thought to be related to migraine. There's been several trials showing doses between 100 to 400 can reduce migraine frequency and severity. And there's even some data showing it decreases CGRP levels. CGRP is a common target in migraine medications. These are your monoclonal antibodies like Emgality or Jovi, or your G-bands like Nurtec and Ubrelvy. So, CoQ10's working on sort of similar mechanism, not mechanism, but the target, if you will. And there's been a lot of meta-analyses showing that alone or combined can be beneficial. It's very common that these three treatments I've just talked about are combined. You'll find various products that have 2 or 3 of these as one. That's very popular. And also CoQ10 previously and commonly is taken for cardiovascular benefit. It's had to mildly reduce high blood pressure. A lot of people with diabetes, it could be protective in cardiovascular events. And also it helps with the side effects of statins. Statins are your cholesterol reducing agents, and common side effects are fatigue or muscle aches, and CoQ10 can reduce that. And again, it's well tolerated. There really are many side effects besides mild GI upset. So going into now exiting the trifecta and just other supplements with evidence, I actually am a fan of feverfew. Feverfew is from natural plants, been used for centuries to treat headaches, and that there hasn't been as much clinical trials compared to this, like MAG or B2, but there are still some that show it can help with reducing headache severity and reducing the intensity of migraine pain. The typical dose is 50 to 100 milligrams. I want to stress that because most retail bottles actually are huge doses. And again, while they might say magnesium on it, I'm always cautious about that, because not that I don't know of a feverfew overdose, but again, when patients ask, they say, hey, this is what the trials were doing. I don't know if I want you taking such a high dose. So keep in mind, usually 50 to 150 milligrams is what I recommend for my patients. Side effects are mild. There's been reports maybe some people have like mouth irritation, mouth ulcers, or the digestive upset. If you have an allergy to the ragweed family, it's not recommended to take, as again, this is the derivative of a natural plant. And again, because the quality and quantity varies completely, I do recommend showing the supplement you take to your healthcare provider. The thing about natural remedies like this and other plant ones I'll discuss is they're not as, at least in the United States, regulated, so you don't know what fillers and other things in, so always be mindful of that. Butterbur, which is another plant-based treatment, has a very interesting history. So this has been trials that has a great efficacy, but for a while they're actually banned. And it's because they were found to contain something called, I'm going to pronounce this wrong, it's pyrrolizidine, which is a hepatotoxic, so bad for your liver, product within it. But then it was thought that all Butterbur had it. No, actually, then it was discovered later on. No, there's a way to produce it that it's PA-free. So you'll still find doctors. I find them to this day would be like, oh no, don't take Butterbur. It's bad for your liver. Most of those ones that contain PA have been banned from the market. I've not seen one that has it. Every label I've seen has say PA-free. So make sure if this is the thing you want to try, it does say that. But there is still concern of those who may be pregnant or lactating. That's questionable. Of course, talk to your doctor. But again, the evidence has been quite high for this. But again, mention it to your provider if there's any concern for liver stuff. That can be easily monitored with liver enzyme testing. So I'm a really big fan of fish oil. The trials behind omega-3 fatty acids are pretty robust. There have been 2 that I've been big fans of. So omega-3 polyunsaturated fatty acids, you might see these on supplements. EPA, DHA have an anti-inflammatory effect. They're used a lot for individuals with cardiovascular issues, reducing cholesterol, et cetera. There have been a variety of randomized clinical trials showing omega-3 supplementation. Doses range from 1.5 to 6 grams. Is what's been tested. The natural typical, like what the average human intakes is 1.5 grams a day. And again, the reduction has been, pretty significant given that this is a natural treatment and not a prescription, something prescribed to a pharmacy. That's been shown to reduce the number of hours of headache, the new headache days, and also the intensity of attacks. And again, it's typically used also for cardiovascular health. So if you're an individual who is okay, I have migraine, but also a cardiovascular situation, this is a two for one thing. Side effects are interesting. So fishy aftertaste is real. If you burp it after it, the patients report that. Also, there is a small increased risk of bleeding. I've had patients report having nosebleeds after. If you notice that, that's a reason to stop. If you choose to supplement it through food, which I want to talk about in my next slide, bear in mind of, where it's sourced, because certain fish could contain mercury. If you consume a lot of areas where in the ocean mercury is high, you don't want to get mercury poison, of course. So fish oil supplementation, doing it through a pill is one way, but also you could consume it in diet, and there's a variety of ways. And again, it's omega-3, meaning when I say fish oil, it's specifically omega-3 fatty acids. So fishes are high. That's why you see fish, very high up on the table. But also if you're a vegetarian or you don't like fish, it doesn't mean, okay, I can't get this. There you could get it through flaxseed, chia seeds, walnuts, etc. There are other foods you could consume if you don't want to take a supplementation. There's a whole variety. I'm a big fan of actually bringing up with patients flax seeds or chia seeds because they're high in fiber, which is also very beneficial. So next I'll be talking about melatonin. Melatonin is a bit of an unclear one, given that there's actually several proposed mechanisms. One is that melatonin has neuroprotective properties and it's a potent antioxidant. There's various anti-inflammatory properties. So their cytokines are these inflammatory signals our bodies release. Interleukin, 1B, TNF alpha, interleukin 6. And again, it's believed to, bring these levels down, therefore playing a role in chronic neuroinflammation. We don't interact with serotonin, dopamine, and GABA, which are involved in the migraine attack cycle. We know it also is mitochondrial protective, which we discussed with other supplements, is also a mechanism that we want to target. And of course, sleep. It affects the circadian rhythm regulation, which is how we know to feel tired and whatnot. And disturbed circadian rhythms or disturbed sleep is linked to migraine attacks. I am a very big proponent of assessing sleep in my patients. Sleep is a critical function for reducing inflammation. For a while, people didn't know what sleep was for, meaning why do we need to sleep? When we sleep, our hearts beat slower, our lungs are going slower, our stomach's not moving. What is happening when we sleep? Well, when we sleep, our what's called your lymphatic system, I guess some neurologists like, let's take the lymphatic and add a G to it. I don't know, I'm not a neurologist, I don't know. What the lymphatic system does is it cleans the brain. So thinking, talking, feeling, that takes neuropeptides, neurotransmitters, like a fuel as a byproduct. When we sleep, it cleanses that. That's why you feel icky, groggy when you don't get good sleep. So if you have sleep issues, melatonin, can help regulate that. Of course, I want to disclaimer say that if you're suffering sleep issues, you should be assessed for sleep apnea and other sleep disorders. Melatonin is not going to fix that. Dosing range is 2 to 5 milligrams. I want to stress that dosing vary clearly because too much melatonin is an issue. It's very common. People will go for the extra strength, 10 milligrams, because I take extra strength Advil, ibuprofen, whatever. Melatonin is different. If you take too much melatonin, you actually suppress your natural production, and that will result in early awakening or interrupt the sleep cycles. So I recommend for all my patients to start with just 1 milligram. Vitamin D is a very common one. A lot of people take it for bone health, calcium, muscle function, etc. There's been evidence to suggest that it supports neurological health and neurodevelopment and regulating neurotransmitters. It's thought to help reducing migraine frequency and severity of neuroinflammation. It's common we check for vitamin D deficiency. Dosing is all over the place. You'll see it's not dosed in milligrams. You'll see units, so 800 to 50,000. I recommend if you want to take vitamin D to do a vitamin D test. And the reason why is if you're vitamin D deficient, you want to take a higher dose. But if you're not deficient, you don't want to take a really high dose. So it is worthwhile to know that. Again, excessive dosing can lead to issues. Vitamin D is what's called a fat-soluble vitamin, which means unlike when I was talking about vitamin B2, it's not easily removed from your system. So, of course, consult with your provider before starting vitamin D supplementation. Ginger or ginger root is another one. It's historically known for antiemetic or, gastrointestinal benefits. There has been some trials done for relieving migraine attacks, preventing migraine attacks. There's not as high evidence as the previous ones I discussed, so that's why I had it for last, but it's a pretty easy thing to introduce to one's diet. Of course, given that this is a gastrointestinal one, it can cause for some individuals mild digestive upset, but it is pretty safe. Now, overall, I like to talk about a lot of supplements. Of course, consult your healthcare provider for starting one. Everyone has unique medical history. The last thing you want to do is take something that might have a negative effect or interfere with something you may be taking. You know, a lot of natural supplements can interact with prescription drugs and affect the metabolism, and that can lead to not so fun side effects. Again, natural does not mean it's always safe. You know, absolutely not. You know, there's a lot of bad things in nature. And unlike prescription medications, any amount can be purchased. You can't, you know, with prescription medications, you can only get so much. You could buy as much you want from a pharmacy or a chemist, and you know, limitation must be imposed. And again, I stress, if one treatment works for someone, it doesn't necessarily mean it'll be effective for you. So if it's not, don't get stressed about that. Migraine's complicated. That's why headache specialists like myself exist. So, you know, incorporating this, you know, this goes into a bigger picture. You know, try one new therapy at a time. If you do multiple, you're not going to know what works. Headache diaries are paramount. It's critical. That's very useful for both you as the patient and me as the provider in keeping track of things. Always look at where it's manufactured. You know, unlike, for instance, prescription drugs, which are regulated by the government, these aren't as regulated. So you want to know what, you know, how it's being produced. And of course, lifestyle factors, hydration, nutrition, sleep, exercise are also important in this. And as always, communicate with your healthcare provider about this. Common questions I get asked regarding, you know, supplement therapies like this is, what should I try first? And typically I mention to people, you know, magnesium and vitamin B2 is common. Things like yoga, meditation, you don't need to buy something. You can easily do that watching a YouTube video or something. Those are really easy. Kind of combine multiple supplements. Yes, absolutely. You want to, of course, monitor and avoid interactions. Try one thing at a time. If you take a combination pill at first, that's perfectly fine. How long should I wait to judge effectiveness? I get this asked all the time, of course. Very valid question, too. Typically, we're like 8 weeks, at least 8 weeks. This is slow. We're changing brain chemistry. I tell patients it's unrealistic to expect an instant fix. It's not really a thing. These things do take time. That's why headache diary is paramount. Are there interactions with my medications? Absolutely. And that's why I bring up speaking with your healthcare doctor. A lot of these might affect, for instance, feverfew and fish oil can affect platelets, therefore thinning blood. Your liver is the great metabolizer, so it can affect your liver enzymes and how other drugs are absorbed and metabolized. So it absolutely can. That's why if you're taking a variety of prescription medications, do consult with your healthcare provider before starting one of these. I want to thank everyone for listening. Of course, thank you to Carl and Australian Headache Society for inviting me to give this talk. Very happy presenting to, you know, Australia, being Carl knows this. All my favorite music comes out of Australia, from Melbourne. Tame Impala, King Gizzard. So thank you to Australia for making these things. On my website, Headache 123, I have a blog on this stuff. I'm trying to, you know, fight the crazy stuff on TikTok and Instagram with good information about migraine. So I put out stuff there. And again, thank you everyone for listening.
All right. Well done, Dr. Cohen. Thank you so much. I really appreciated your frank candor and just really your down-to-earth style. We're going to transition now to Q&A. Andrea had a question about what form of magnesium, what dose and frequency, for example, how many times a day would be optimal for migraine? I've heard mixed reviews.
There's actually a couple ways to go about this. There's once, multiple, and there's no right or wrong. So the total dose could be between 325 to 500. Where does this number come from? This number actually comes from just, there's been a lot of assessment at like, all right, where is the effective amount? And what they really found, looking at all the trial data, is once you pass 500 milligrams, you have diminishing returns. That's why I never recommend more than 500 in a day, because you run a higher risk of a GI side effect, loose bowels, etc. You could do it either 200 in the morning, 200 at night. You know, you do it like that. I actually am a big fan of taking it all at night before bed. Mag has like this calming effect. It's actually sold as that a lot of the time, that it's sold as sort of this like relaxed anti-anxiety. It does have those properties. I don't think that's a sham at all. It does have that. So I would recommend a lot taking it 30 minutes or so, an hour before bed. So it's sort of use it for that effect and whatnot. But there's no issue doing it twice a day. I don't recommend 3 times a day, but if you want to take morning and night, that's fine as well. Just again, I don't see a point in exceeding 500 in one day.
Great. And was there a format that you prefer? Like I've heard about chelated magnesium, like glycinate is quite, it's more sort of readily available, less likely to cause side effects versus other forms. Is that the case for you too?
There's a lot of forms. Chelate is a fine example. And what I tell everyone is, finding what works. I'll give an example. My body is very sensitive to magnesium. In fact, I've not found a formulation that I could actually tolerate, but that's me. And I have people that have found that, oh yeah, I can only use chelated, I can only use threonate, I can only use glycinate. And that's sort of my point, that there's no form that is what I call superior. Otherwise, I wouldn't have given any options. I'll be like, here, take this specifically. It's, explaining how mag works, and then also explaining, hey, if you run into issues, don't run away from it. Like I've had patients that literally have said, oh, when I finally got a powdered version I can mix in water, that worked great for me. Oh, I found one that's a gummy. I found one that I actually can, I put in my food or my smoothie, whatever. There's no one that's better. It's just finding what, doesn't bother your stomach, essentially.
Right. Nikki had a question that she'd like to know more about the link between gut health and migraine.
Sure. So this is a very popular topic, of course, in medicine right now. Because let's just go back to the same learning school: you are what you eat, in a way. So the gut biome, which we're still learning about now. Like when I go to conferences, I still learn more and more things. That is a major source of how we absorb nutrients, supplements, etc. And also, if your gut biome is angry, a source of inflammation. Now, if you're an individual that has sort of any kind of gastrointestinal issue, of course, working with your GI doctor is paramount. But when it comes to the gut biome and talking about migraine health, it's important eating foods that are beneficial to that. For instance, fermented foods are the most popular ones: yogurts, kefir, sauerkraut. I love eating kimchi. Kimchi is actually phenomenal for that. Any fermented foods, because these are natural probiotics. Probiotic, capsules, there's a little bit of I don't want to say sham, but there's a lot of evidence that a lot of those good bacteria in capsules are actually dead. They don't survive the process of getting into you. You actually will find in health stores a lot of refrigerated ones, so they're preserved. I usually tell patients, if you want to take a probiotic, take natural ones, because they'll actually be in there. And of course, be sure to do it with fiber. Fiber, you don't want to stress the GI tract out. So gut biome is very important, because again, if gut biome is unhealthy, that could be a source of inflammation. And migraine at its root, if you were to define migraine in one sentence, it's a condition of neuroinflammation. So any aspect of reducing inflammation will be beneficial for your migraine.
Yeah, and it seems to play a role. Like we see nausea and vomiting so common during a migraine attack. We also have gastroparesis, which is like the tightening of the stomach during an attack, which stops the absorption of migraine. So there is a really strong link between the gut and the brain and
Absolutely.
migraine.
It's also, remember, in children, that's how migraine commonly presents: abdominal migraine. A lot of, I bet many listeners here, if you didn't have the actual headache attack in childhood, I bet many of them suffered from either frequent car sickness or nausea, vomiting as a kid. It's a very confirmed link.
Absolutely. We had another question here about how to manage migraine during menses and pregnancy.
That is a very top, I could talk about that for hours. So in keeping with, this, menstrual cycles I'll start with that. It's very common for women to have more frequent or severe attacks during a menstrual cycle. It's estimated as much as 70% of women with migraine may suffer an attack specifically in relation with their cycle. And the reason for that is we know estrogen is related to the migraine attack. Estrogen has a neuroinflammatory pain property, if you will, and it's not a decrease it's not high or too low, it's a fluctuation. It's a different amount, and that's how your body reacts. So there's no supplement, just thinking in, the topic of the talk, I wouldn't say there's a supplement that's best for that. When it comes to menstrual migraines, it's always first of it, you're identifying that that's I don't want to say trigger, but part of your migraine attack cycle, and then being prepared that it's common that my patients with more specific menstrual migraine attacks have certain abortive therapies that they take specifically for that time. Now, pregnancy is a much more complicated scenario, mainly because many of our treatments have not been tested in pregnancy. I'll even do you one better. It's a very fun time in the United States. I don't know, for those who are up to date in current events. Our Secretary of Health and President have announced a link between Tylenol and autism during pregnancy, which many of the medical community disagree with. But there's a lot of treatments that are not approved, like triptans and G-pans. So, that is something I always say is a specific treatment plan with your provider, because it's different for everyone. For most women, the first trimester, that's the doozy. That's the more painful one, because there's such a fluctuation of estrogen and other hormones. Most women actually have lesser or even migraine free for the second and third trimester. That's a very common presentation. And I want to stress, that's not for everyone. I have patients who have no migraine, horrible migraines. It's all over the place, but that's the typical presentation. And again, if that's something to discuss with OBGYN, because it's getting you over that hump, that first trimester. Because again, for most, the second and third is fine. And it's also important to keep a note if you plan to breastfeed. After delivery, a lot of medications come back on the table, not all of them if you're choosing to breastfeed. Now, I always tell patients, don't let that interfere with your decision to breastfeeding your infant. As we know, breastfeeding is very beneficial, has a lot of health benefits for an infant, especially for immunoprotective properties. And know that there are still a lot of treatments that can be done in both pregnancy and breastfeeding. My most popular one is actually nerve blocks with lidocaine. That's localized injection of lidocaine around the head. And that's because it is a confirmed safe treatment in migraine, meaning that we don't have to worry about it. And again, it's not a long-term thing. We just, we're getting you through this time, so it's the most safest for you and your child.
Yeah. Yeah. And you can't assume that all supplements are safe either in pregnancy, even though it's easy to buy.
Exactly. And that sort of goes with what I was saying with the ingredients. Any especially natural stuff, mag and other stuff is different, but any sort of natural that is plant derived, I do stress, show your GP. Because again, how they're sourced, there's not a strict regulation. There could be natural things. Again, just because something says all organic, I'm not like, I take supplements, I'm not like, oh no, take only, manufactured junk. No, but listen, again, let's go back to the story of aspirin. Aspirin is a great medicine. But aspirin, where it comes from, salicylic acid, it's in tree bark. It's designed as a natural deterrent so bugs and things don't eat it. We have sort of, our ancestors, ancient medicine is they would take the bark and burn it, and that ash they would use as medicine. We figured it out. But it's technically naturally a poison. Look at Botox. It's one of the most popular migraine treatments. That's a neurotoxin. And it comes from nature. It's derived from a natural, real anobotulinum. My point being is, just because something says all natural, a high consumption of it can be a thing. When I used to be a GP, before I did headache specialist, I was a primary care doctor. And I saw mainly actually in our immigrant population. I did my practice in Bronx, New York. We have very high immigrant population there. We'll be taking natural supplements that actually, these, an example, the betel leaf. Betel leaf is common among South Asia, very common. It's natural, and it's a major cause of oral cancer, even though it's a natural thing. So that's why I stress any kind of natural supplement, just show it to your GP. Then most of the time they're gonna be like, okay, don't think they're gonna shun you, but if there might be something in there you're not aware of.
Yeah, yeah. And hopefully, you can bulk bill that GP visit. You can also speak to the pharmacist, which is often free. You just ask for the pharmacist behind the counter.
That's another very good point. Pharmacist knows this thing too.
Yeah, yeah. All right. Well, thank you. You've been very versatile in your questions, and the versatility is continuing. I'm going to ask you now about vestibular migraine from Lauren. Do you have a best or preferred treatment for that type?
Yes. So vestibular migraine, very common subvariant. So for those who don't know, it is migraine with aura, but now your most common aura symptom is like the kaleidoscope, zigzags. It could be any neurological symptom during aura, and in this case, vertigo, vestibular symptoms, issues with balance, and coordination like that. So it's still treated as a migraine. That's the overarching, theme of any kind of subvariant. You still treat the migraine because the theory then is treating the migraine, you're going to treat the overall condition. With that said, specifically, there's evidence that SNRIs, serotonin norepinephrine reuptake inhibitors, such as duloxetine, which is Cymbalta, I don't know if this is a different name in Australia, or venlafaxine, which these were invented as antidepressants. They're very common neuro painkillers. We use them all the time, first line and for migraine care. There's evidence that they're more effective than not for vestibular migraine. But again, or when I meet a patient like that, we still try out mainstay things. I have many vestibular migraine patients on things like magnesium and riboflavin. They're doing Botox, they're doing CRGB treatments. Again, you're still treating migraine. It's just, okay, now we have this subvariant. There might be other treatments we pick first. Vestibular physical therapy, meaning specific physical therapy for that, is great for that. Atarax, which is hydralazine, which is an anti-vertical medication, is useful abortive. But again, the hallmark is we're still treating the migraine. If needed, there are typically vestibular experts. It's not uncommon, not all the time, but sometimes I do reach out to a vestibular colleague of mine for joint, collective collaboration if those vestibular symptoms are that significant.
Yeah, and I don't think many people realize, or at least we hear all the time, that actually they're taking a generic migraine preventive, a CGRP antibody, for example, and as their migraines improve, so did their vestibular migraine. Their balance and dizziness issues all kind of got a lot better as a result of that.
Migraine is not just pain. Migraine is not just a headache. Migraine is a multi-phase, if you will, neurological condition. And that vertigo, that aura, is one of those phases. So again, you're treating the overall condition. We know CGRP is a major neurotransmitter, has a major role. So it's not that, you're treating the pain per se. Yes, you're going to improve the pain, but you're also treating the overall condition. So that's why it's still, all right, we got to treat migraine.
Georgia had a question about how can people with chronic migraine better advocate for themselves in medical appointments or in the workplace?
They say you are your own best advocate. And unfortunately, in the migraine world, we face a lot of stigma. I'll go in personal experience. My whole life, I didn't know I had migraine until my second year of med school. And where they were describing in the first neuro lecture, where I grew up every week, once a week, I would get a severe headache. I would have to, as a kid, leave school. And I just thought that was normal to get a serious, severe 10 out of 10 pain headache. And I just thought that's just life until literally in this lecture. And I'm like, what? Sumatriptan, what? And then when I met my first headache specialist in, residency, that's when all right, man, it was life changing. So, even though I've met with neurologists before that, no one really helped me. It's don't lose hope, meaning make sure how do I want to say it? Your needs are met. If, a lot of medicine is taught about, I don't want to say saving a life, but make sure someone isn't dying, which is obviously very important. Migraine doesn't kill, but that doesn't mean the symptom's not real, meaning that a lot of physicians may incorrectly just think, okay, I did an MRI, I did blood tests, you're not dying, you're good, but the pain is there still real. So you have to advocate hi, thank you for doing that testing. I'm still suffering in pain. I'm still burdened. If, again, if you reach a wall, okay, I don't know, then unfortunately that provider's not doing what I would say a reasonable level of care, and you'll have to find, another one. But it's it's not just stopping at everything's fine. The pain is still real. And you may, hopefully, I hope you don't have to advocate. I met many patients like that when they've explained these symptoms to their primary care or GP or the neurologist. They're just like, drink more water. Have you tried drinking more water? And it's, I don't want to say be gaslit, but if that pain's there, that's real. It's no issue to then, if you feel you're not making progress with your doctor, to find another.
Yeah, and I think understanding what are realistic goals, and that only comes from attending, events like this and learning about migraine. But if you know that there's treatments out there that if you just take that treatment, it can reduce your attacks or severity by 50%. Well, then if you're not getting that from your doctor, you can say, hey, isn't this a reasonable benchmark to be asking for? And hang on, if I combine, I'm doing multiple things here. If I combine that with my medication, shouldn't we be aiming for an 80% reduction? And if you know that, but the doctor doesn't know that, then you can stand up and request it and, sometimes demand it. And I think the challenge that a lot of us have is we're reluctant to change doctors. Some of us don't have that choice if we're in regional or rural areas, and you kind of have to just work with the doctor you have. And that's where it's even more important to understand what your options are, the different treatment options, the combinations, and what success should look like for you, I think.
This is something I'm working for in the United States, where again, I'm especially starting rural areas, areas that don't have robust healthcare systems, where all they have is a GP. And I work very closely with the American Headache Society. I serve as the section chair of the primary care interest group in the American Headache Society. I'm going to be hopefully creating a similar committee in the International Headache Society, because you're right, we need to educate these providers. And again, it's more of, I will say this, explaining to a doctor, I think I have migraine, meaning when they just hear headaches, I'm having headaches. Okay, it's just headaches. Take an Advil, drink more water. But when you say, oh no, I think I have migraine, doctors know that's a different thing. That's not just a headache. So again, I tell patients, don't be afraid to say, I think I'm having cluster headaches. I'm thinking I'm having migraine. Because you want to get through your provider's ear as they're doing multiple things. That's also another issue. There's so many things we have to do in a visit. I wish I would always have a limited time my patients, but unfortunately that's not how the system works. But by saying, no, I think this is more than a headache, this is one of these other conditions, okay, hold on, I have to listen more to this.
Yeah. And Carmel, Georgia, will answer the second part of that question on Friday. If you're back for that session, be happy to chat more about migraine in the workplace. Carmel had a question about cervicogenic headache and whether they're related to myofascial pain.
Sure. So cervicogenic headache, the Latin, which is cervical, of your neck. And I have something very useful for this. Hold on. It's very good you asked that. I am prepared all right, this is my friend. Also, I use it to carry my Stetson hat. All right, so cervicogenic headache, looking at neck muscles. So think of the neck muscles like a pulley system, right? So you have so many neck muscles here. You have spinatus, capitis, semispinatus. You have a bunch of stuff, paracervical muscles, occipitalis, and they're like ropes here, And when they're angry, they pull, they contract, they're inflamed. And when they do that, they pull on your occipitalis, and then they pull on your temporalis, and then they pull on your frontalis. And that's why it's really common. You might feel, some people might actually have a headache here. And then when I bring up neck stiffness, not even neck pain, stiffness, they go, oh yeah. And it's like, hey, it might be an issue here. And that's a very real thing. And it's very common that many people with migraine do have ongoing cervicalgia, neck pain. It's a chicken or the egg scenario. Bottom line is treat both. I've sent many people to physical therapy, many people to massage therapy. I've given muscle relaxers, trigger point injections. So trigger point injections are like what I call the Western medicine of acupuncture, meaning I have a similar technique as acupuncture, where we have a very fine needle. Not as small as acupuncture. We have a fine needle. I'm going in and out of your knots, those trigger points of your trapezius muscles and neck muscles. But it's also syringe. I have lidocaine. I then inject lidocaine or bupivacaine into that muscle, and that serves like a chemical massage. It forces, the knot to sort of come undone and relax. So neck pain is, absolutely common thing. If you feel you have migraine and neck stiffness, I highly implore you to, get your neck checked out. Not saying you need imaging, but see a physical therapist about it. See a massage therapist, and if maybe even explore trigger points. I tell patients, if trigger points make your headache feel better, that's almost diagnostic, because now you've removed the inflammation of the muscle. And again, it's usually these things aren't, a one, this is it, this is the cure. Migraines are usually multifactorial. There's usually multiple things. It's not just one thing we, tweak it and aha, we did it. It's usually a multitude of things. And the neck is a common one. And again, it's getting these pieces of the puzzle and how we further reduce the frequency of attacks and severity of attacks. And I see someone sees my cat. Yes, my cat walks around. I heard her during the talk. That's my lovely assistant.
If we've had a request to see the cat, so if she's around, you can feel free to put her on show.
Oh, careful what you ask for.
I know we're coming up to the top of the hour. You've been very generous with your time and expertise, and we've taken you.
My pleasure.
We've taken you all over the migraine landscape, and there's the cat.
This is my Bengal cat. Hello, my child. That's what it's all for.
One more question to sort of wrap up, or maybe two, depending on the time. Leanne had a question, which I think we answered, about natural approaches for vestibular migraine, which would be the physical therapy aspect. David had a question about, what are your thoughts, recommendations regarding antihistamine or a zero sugar diet to help reduce migraine?
Sure. So first, let's talk about histamine. Histamine is related. We know the actual, chemical per se in the body is related to migraine. However, it makes people think, okay, let me take antihistamine treatments, and that's not necessarily true. If you take things like Benadryl, for instance, very frequently, long term, that can have negative side effects. So I just want to, make that clear because some people hear, oh, histamine, I got to take antihistamines. So it comes down to sort of dietary things. There's a lot of dietary answers to this, and it goes into how everyone's bodies react different. Meaning, yes, there are some individuals who have had success eating foods that are low in histamine, but that doesn't necessarily mean that might be successful for everyone because some people just naturally, produce a lot of histamine or there's other triggers. Because also, histamine typically gets released in the body through, I'm going to say, body stress, meaning not the actual act of stress. It's when, mast cells essentially rupture, they break, and they release histamine. So it's not necessarily a histamine diet. Now, there are other associated symptoms such as MCAS, mast cell activation syndrome. That's essentially where usually mast cells are immune response. So when there's an intruder, something wrong, histamine, get it, like bring the other, white blood cells to fight it. It's a condition where just your mast cells, unfortunately, your body thinks it's in danger and activate and release of histamine. Not everyone has MCAS. The signs of MCAS, by the way, is when if you get like a lot of bright, like redness in your cheeks and like rashes, hives during a migraine attack, that could be suggestive MCAS. Again, that could be tested with your doctor. But again, going back to the main thing, you could certainly try a histamine diet. There's many different diets for migraine. There's not one to rule them all. I've had success with people with keto, Atkins, gluten-free, vegetarian, vegan, and they've all had success and failures. It's try it. Try one at a time. For a month, go vegan. For a month, don't eat chocolate. For a month, low in histamine. And you might find one that works. But I also stress about supplements. Make sure you do one change at a time. Otherwise, you might not know what works.
Yeah, I think that I've spoken a fair amount to people about diet, and I think that usually when we go on a diet, we're eating better than we otherwise would. We're eating less processed foods. We're going to take away less. And
right, you're being more focused on it. Yes.
Yeah, yeah. And then as a result, our migraine gets better. So almost in some respect, we always get like this positive response from a diet. The challenge is keeping a diet that is sustainable and that kind of works for us. But I think that anything we do to reduce the amount of processed food, which is where we typically see the most amount of problematic ingredients and MSG and dark sauces and excitotoxins, et cetera, that can kind of cause this hyperreaction that we're trying to avoid, is helpful. But again,
and even not even starting with a diet, keep a food diary at first if you want to, because you might find after hours eating, consuming certain things, maybe high in nitrates, or high in sodium, etc., that you might find dietary triggers that way. The headache diary is so paramount because, when you go to a doctor's office, it's human. You're going to get pelted with all these questions. And to remember, first of all, you only remember the most severe attacks. Every headache matters. So that's why keeping a headache diary, you keep it on your phone, keep it on a small notepad. Basically, what I ask my patients is, the day it happened, how long it lasted, how bad, where was it, and what were you doing? That's it. Nothing more. It doesn't have to be sentences. It's usually just a couple of words. And then you build that over time. You bring it to your doctor, and then I decipher it. You don't have to decipher it. That's my job. I tell patients, don't try to make sense of it. That's why you're coming to me. And then, this is a true story. There was one patient who, over the course of about 5-6 months of a headache diary, long story short, I figured out her trigger was eggs. Why? I don't know. I can't give you that answer why eggs were her trigger. But I cut out eggs and her headache frequency went down a lot. I don't know why that's the case. However, then she tells me, what do I do? My favorite food's omelet. And I'm like, all right, I don't have to tell you. I found your trigger. Sorry, it's egg substitute for you. But the point is, that was her trigger. Everyone's migraine, everyone's headache is different. Everyone's body responds to inflammation and sources of inflammation differently. For whatever reason, her body, that's how it responded. So, and I don't want everyone in this chat not to be like, no more eggs. No. But that's why you keep a headache diary.
That's a brilliant way to end. Thank you so much, Dr. Cohen, for being so generous and
versatile. Thank you guys for so much for having me.
We really appreciate your contributions, and thank you to our audience, to everyone for attending. We're back again tomorrow night at 7:30 Australian Eastern Time with Dr. Bronwyn Jenkins.
I would love the consult in Melbourne. Anyone can bring me to Melbourne. Anywhere in Australia, I would love that. It's one of the few places in the world I haven't been yet.
We would love to have you here. We'll find an excuse to get you here. All right. Well, thank you, Dr. Cohen. Thank you, everyone. We'll see you again tomorrow.
Thank you.